Great. I think people are trickling in, and just in the interest of time, I'll just go ahead and start maybe the introduction. Hello, everyone. Welcome to our webinar. I hope you're all having a good afternoon. It's noon now. My name is Beza Gabrihana, and I am the Public Relations Manager here at the Center for Innovative GYN Care. This is our Ask the Expert webinar, a series that we're launching today. This is Understanding Endometriosis workshop. And as you all know, this is in the Endometriosis Awareness Month. And so in an effort to raise awareness about the condition, we have invited our own expert, Dr. Natalya Danilyants, to come in and join us and provide an insight onto this topic. So just a little logistical things that we need to go through before we get started. My role today is going to be really to help facilitate our conversation so that this session goes smoothly. You would hear me interjecting with comments, questions from time to time, but the majority of the conversation would be happening via Dr. Danilyants. With that said, although we are all virtual, I'm going to encourage you all to ask your questions. We have a chat box. If you don't see the chat box, you can just hover down at the very bottom of your screen, and there should be a three dots that says more, and the chat box option would be there. Click on it. Any questions throughout the webinar, go ahead and type it in the chat box, and we'll be able to address them. It's not rude to ask questions while Dr. Danilyants is presenting. Okay, so after the webinar, I would send out a survey as well as the PowerPoint presentation alongside any resources that would be shared during the webinar. All right, if you guys are ready to get started, I will go ahead and introduce our speaker, Dr. Danilyants. Dr. Danilyants is a board-certified gynecologist who has extensive experience in treating complex GYN conditions such as fibroids, endometriosis. Dr. Danilyants has developed and perfected the dual port GYN and LAM method, which she would talk about later on in this conversation. It is an honor to have her here with us. So without any further ado, I'm going to go ahead and pass the mic over to her. Just so to set us with the PowerPoint presentations. And Dr. Danilyants, I have made you a host. You can start sharing your PowerPoint presentation.
Great. Thank you so much for the introduction. But yes, I do have quite a bit of experience with endometriosis. I've been doing surgeries for over 15 years, and our practice specializes in endometriosis and fibroid treatment. So we do see a lot of endometriosis. Sometimes it's very mild, sometimes it can be severe disease, and we do treat all of those conditions. So let me get this screen sharing thing. I don't know why it's doing that again. Okay, hold on a second. Maybe this one. Share this one. This one. Okay. All right. I think you should be able to see it now, right?
Yes.
Okay, great. Excellent. Excellent. All right. So today we're going to be talking about endometriosis. I want to make this kind of more conversational and give, a lot of patient examples from my experience. I think that everyone will be able to relate. So rather than just talking about the definitions and kind of reading from a textbook, again, I want it to be relatable because I think that a lot of patients have had similar experience to what my patients experienced. And I think, again, it's going to be easier to learn and understand from examples rather than from just textbook definitions. All right. So today, the goal of our presentation is to increase awareness and knowledge about endometriosis, including the symptoms, diagnosis, and treatment options. Again, I'm going to use a lot of examples that from my personal, experience as a provider. We're going to talk about up-to-date information about endometriosis to help reduce misconceptions and stigma surrounding the condition. And really, the goal is for us to encourage early diagnosis and treatment for endometriosis, highlighting the importance of recognizing symptoms and seeking medical attention, and really seeking second opinion if your provider is not, doing what you think they should do. So what is endometriosis? Endometriosis is a gynecologic condition that happens when tissue that's similar to the cells that grow inside the uterine lining start growing outside of the uterine lining. So you can see this picture of the uterus on the right-hand side. This triangle area we call a uterine cavity, and the endometrium is the cells or the tissue that line that uterine cavity. And that same tissue is what a period is. So when a menstruation happens, it's actually shedding of that uterine lining. And then with the next cycle, uterine lining grows, and then it continues to shed. So this happens over and over again, and that's the menstrual cycle. Now, when these, again, cells that can grow outside of this area are not normal, so we're calling them abnormal cells. So when these abnormal cells grow in the uterine muscle, then it's of the uterus, but they're in the uterine muscle outside of this triangular uterine cavity. When the abnormal cells grow outside of the uterus completely, we call it endometriosis. And this tissue can implant on structures. It can implant on the outside of the uterus, can implant on fallopian tubes, on the ovaries, or it can implant on the surface of the bladder or the bowel. Or even in the upper abdomen, like diaphragm. And in very rare cases, it can implant completely outside of the abdominal cavity, like in the chest cavity. Endometriosis is estrogen-dependent condition. So what does that mean? So we don't see endometriosis typically in postmenopausal women unless there's other source of estrogen production, and I will sort of cover that later during that presentation. But most estrogen is produced from the ovaries, so we see it in women who have started menstruating. So it could be, at the age of 14 or 15, and then we see it all the way up to, women in their 50s, kind of before they enter menopause. So that's kind of the most common age range. Oops, sorry. So what are the symptoms of endometriosis? Painful periods. So that's sort of a classic symptom, right? Endometriosis can cause severe pain during menstruation, pain in the lower back, lower abdomen, pelvic area. The pain doesn't only have to be during the menses. It can start, a week or two before. Some patients with endometriosis have pain most of the month. So even if they're not experiencing, if they're not bleeding, they can still experience pain. Heavy bleeding can also be a symptom of endometriosis. It can be especially a symptom of adenomyosis. That's again the condition where those abnormal endometrial cells are growing into the uterine muscle. The abnormal bleeding can be heavy bleeding, it could be prolonged bleeding, or it can be bleeding between periods. So all of those things we describe as abnormal or heavy bleeding. Infertility, so inability to get pregnant within a year, can be a cause of endometriosis. And sometimes endometriosis is the cause of what we call unexplained infertility. So what is unexplained infertility? That's when you go to see a fertility doctor, they do all the tests, they do hormone testing, they do semen analysis, they do a complete evaluation, and everything seems normal. So there is sort of an unexplained cause of why, a young patient cannot conceive. And so endometriosis can be a cause of that unexplained infertility. What are some other symptoms of endometriosis? So endometriosis can actually mimic other conditions. So IBS, right, is a common condition, sort of inflammatory bowel syndrome. So when you have constipation or diarrhea, or maybe alternating of the two, bloating, abdominal pain, pelvic pain, And a lot of patients end up seeing a gastroenterologist, and they go through endoscopy and colonoscopy and full evaluation. And the gastroenterologist says, this doesn't seem to be sort of GI related, or maybe they give the diagnosis of IBS. Well, endometriosis can actually mimic IBS. So maybe that patient, if in fact does not have IBS, or endometriosis can worsen the IBS symptoms. So again, bloating, constipation, painful bowel movements, especially if those symptoms tend to be cyclical, meaning that they sort of repeat every month. You have this cycle of symptoms that's repetitive, and it's somewhere around the menstrual cycle, then really the diagnosis of endometriosis is considered. Pain with sex. So endometriosis can definitely cause pain with sexual activity. It can be pain during sexual activity, it can be pain after. In fact, I had a patient a few years ago whose only symptom was pain with sex. Her OBGYN actually sent her to a sort of a psychologist or a sex therapist, because that physician felt that maybe there was some underlying issues that were causing her to feel pain. And so she was going around in circles with all these different providers. And finally, she came to me, and we did laparoscopy and found, significant endometriosis. She didn't have other classic symptoms. She didn't have pain with periods, no other really issues other than pain with sex. In fact, her insurance company denied coverage for her surgery because they did not feel that her symptoms were consistent with endometriosis. So, it's one of those things. Again, endometriosis is extremely common, and unfortunately, it takes 12 years. For an average person, takes about 12 years to get diagnosed correctly with endometriosis. So that's over a decade of somebody going from doctor to doctor, going to the ER, really endless suffering, right? And not to have the right diagnosis. It's definitely has a lot of psychological impact when multiple providers are telling you that there is nothing wrong, everything looks normal, and patients really develop depression, anxiety because of that. And I think everybody needs to be aware how common endometriosis is and how important it is from the physical and psychological standpoint to give the correct diagnosis. Now, endometriosis can coexist with other common conditions. Another common condition that we treat is fibroids. So fibroids are non-cancerous tumors of the uterus, which is the womb where also endometriosis comes from. And fibroids are actually present in 80% of women. So they're extremely common. They can be small. They may not cause any symptoms. But for example, let's say you're someone who has pelvic pain, either pain with most of the month or pain with periods, and you go see your OBGYN, and the OBGYN gets a pelvic ultrasound, which is a pretty standard evaluation, and they find small fibroids, and they say, oh, you have small fibroids, that's probably why you have pain. It's not a big deal. The fibroids are too small to really do anything about it. That's it, end of discussion. Well, most likely that patient's pain is not due to the small fibroids. Most likely this patient has endometriosis, and she also happens to have fibroids, which is extremely common. We actually did a study that we presented in 2020 at a congress that was on OBGYN and infertility. And we presented one of our studies that looked at prevalence and coexistence of endometriosis in women undergoing laparoscopic myomectomy, which is a procedure for fibroid removal. And we found that 45% of these patients actually had endometriosis. So we're going in to remove fibroids, and we find endometriosis in half of these patients. And this is actually much more frequent than previously recorded. I think what we're doing different than other providers is that we're actually looking for endometriosis in patients because we know how common it is and how important it is to diagnose it. So even when we're doing surgery for non-endometriosis causes like fibroids or scar tissue or other sort of unrelated conditions, we're always looking for endometriosis because we know that a lot of patients will have endometriosis and not realize it. So stages of endometriosis. Why do we care about stages? So here's the picture of different stages, right? You have minimal stage, which is stage 1, where there are few little spots or lesions or abnormal cells growing outside of the uterus, and all the way to severe stage, which is stage 4, where there's a lot of scarring and inflammation, and really it's affecting a lot of structures. Why do we care about it? Because it's going to really dictate our management. So how we're going to treat that patient. The symptoms can be pretty severe even in stage 1 endometriosis, and they can be mild in stage 4 endometriosis. So the symptoms are often not reliable to sort of guess what stage the patient has. That's why we have to do laparoscopy. We have to actually look inside, and that's when we identify what stage they are and tailor the treatment according to the stage and according to the symptoms. Causes of endometriosis, that's a very common question that really doesn't have a clear answer. There are different, potential causes. There's genetics. So, there are studies showing that, there is some genetic link. Again, let's say if your mom or your grandmother or your aunt or sister has endometriosis, there's an increased risk that you may have endometriosis. Retrograde menstruation, which is talking about those endometrial cells from within the uterus sort of travel through the fallopian tube and implant on other structures. Hormonal and environmental factors, and then some problems with the immune system response. So none of these really, we don't know which one it is, or maybe it's all of them. It's not clear. Previous pelvic surgery, like C-sections, we know increases the risk of adenomyosis, which is endometriosis in the muscle of the uterus. And also those patients are at higher risk for having endometriosis growth in the C-section scar. So that's sort of pretty specific. Also, endometriosis can grow in any abdominal scars, even in the belly button, for example. So what is the best way to diagnose endometriosis? It's through laparoscopy, right? You can have a high level of suspicion. So let's say if someone has all the classic symptoms, they have pain with sex, they have pain with periods, they have pain with bowel movements, pain with urination, pelvic pain most of the month. Most likely, yes, that patient will have endometriosis, but we don't know for sure. We don't know if they have it. We don't know how severe it is, right? I've had a patient tell me that their OBGYN really did not want to do laparoscopy or surgery to diagnose endometriosis because they felt that it's not going to change their management. So they had the patient on birth control pills to manage their symptoms, their pain, and they felt, well, we do laparoscopy, we see endometriosis, we're still going to really continue the birth control pills. What's the point? Well, the point is that before we do laparoscopy, we do not know the stage. And remember, the fertility outcome, really our treatment is going to depend on what stage the patient is in, not just based on the symptoms. So if patient has very mild symptoms and we think we're doing a great job controlling those symptoms with endometriosis, and then we do laparoscopy, those symptoms with birth control pills, and then we do laparoscopy and we realize this is stage 4, very, very severe endometriosis, well, it's no longer appropriate to just continue these birth control pills, right? We are going to completely change our management. We have to be much more aggressive, especially if this is a patient who desires fertility, who wants to get pregnant. We want to, definitely send this patient for fertility treatment immediately if they want to conceive right away, or maybe to have their eggs frozen because it's their fertility is significantly compromised. And the longer we continue to delay treatment, the worse the outcome will be. So the best diagnosis, again, is through laparoscopic procedure. This is an outpatient procedure where we make a small incision at the belly button and we put a camera through that belly button incision. And then we make another small incision for the instruments. And then during that same surgery, we can diagnose and remove endometriosis. So a lot of patients ask, so are you just doing the surgery for diagnosis? No, it's both. You're diagnosing and removing at the same time. Now, I've seen patients, multiple patients actually over the years, who come to me and they said they had laparoscopy, but their doctor only took pictures and then told them, yes, you have endometriosis, but they didn't actually remove any endometriosis. And that's, of course, would be extremely disappointing, because you just went through surgery they thought was going to help you, but it only really gave you the diagnosis. So no, the laparoscopic surgery should diagnose and treat endometriosis at the same time, because now the patient has to have another laparoscopy just to remove the endometriosis. And that brings me to the importance of going to a specialist when dealing with endometriosis, because a lot of times you're not going to know what endometriosis stage, right? What the stage is, and really how what type of surgical skill will be required to remove endometriosis. If it's mild, maybe the OBGYN will be able to do it effectively. If it's very severe, those severe cases do require a specialist. And again, because beforehand we really don't know which one it is, it's really important to go to a specialist right off the bat so that you can get the best surgical treatment. Preliminary tests for endometriosis, it's really not so much for endometriosis. So let's say, again, you're coming to your OBGYN, you have pain. Yes, the first thing to do would be to order a pelvic ultrasound, after an exam. And but however, in endometriosis patients, almost always the ultrasound is normal. So really, the ultrasound is not to rule out endometriosis; it's to rule out other conditions, like ovarian cysts, for example, they can cause pain, or fibroids. But again, even if we find an ovarian cyst or fibroids, we still don't rule out endometriosis, right? We know, okay, these conditions exist, there could still be endometriosis. So depending on, what the symptoms are, a lot of times surgical diagnosis is still necessary. How am I doing? I'm afraid to click on the chat because I don't want to lose my presentation. So
you're doing great. We don't have any burning questions as of yet, but we encourage you to type them in there if you have any questions.
All right, good. All right, so yeah, so surgical excision is the best way to treat endometriosis. So a lot of patients come to me and they say, are you going to do excision or are you going to do ablation? Because that's, when you go online, that's always discussed. So what is the difference? Excision is kind of like if you're going to remove a weed, you have to remove the root. And that's where we're cutting out the endometriosis to make sure that we're taking out the entire lesion and the depth of the lesion. When we're burning tissue, we're only really destroying the top, right? And the root is still there. So there's a higher chance of not completely destroying the entire endometriosis lesion, especially if it's deep. Another thing about ablation is that if endometriosis is on or near a vital structure like bladder or bowel or ureters, which are tubes that go from the kidneys to the bladder, you really can't burn there because you're going to inadvertently burn the actual structure like bladder or bowel. And that is why sometimes surgeons that are not skilled in endometriosis excision will leave those lesions alone. So they'll say, we were able to remove some endometriosis, but there was one area near the bladder and we didn't feel comfortable excising that. So, and again, that's not really optimal, right? Because if you're going to have surgery, you want endometriosis to be optimally removed if possible. There are cases, for example, if I have a patient who is in her 20s, who wants fertility, who's coming in for laparoscopy, we do laparoscopy and we find stage 4 endometriosis that's involving the uterus, the fallopian tubes, the ovaries. In that patient, optimal excision will not be possible because we cannot remove tubes, ovaries, or uterus. So in order to optimally excise all the endometriosis, we would have to remove all the affected structures. So in that case, we have to sort of be more conservative, remove as much endometriosis as possible without removing reproductive structures, and then after that, doing medical treatment So as opposed to someone who is done with fertility, let's say they're in their late 40s, and their goal is optimal excision of endometriosis, then in that patient we will be more aggressive once we realize that the endometriosis is advanced and maybe remove uterus, tubes, and ovaries. So everyone's going to be different. Everyone's age, fertility goals. So really you have to tailor treatment based on the patient and what their situation is. But correct diagnosis is going to be key. Non-surgical treatment of endometriosis. So typically we start that after the surgery, right? A lot of patients that come to me, they're already on birth control pills or some type of method to control their symptoms. But at that point, we still don't know how severe endometriosis is or if it's endometriosis at all. After the surgery, after the surgical diagnosis and the excision, we can either continue with the birth control pills or IUD or a patch or other common hormonal methods for mild to moderate endometriosis if their symptoms are well controlled after the surgery, or we may consider anti-hormone medications. So these are called GnRH agonists and antagonists like Lupron or Orilissa or Myfembree, and there's many others. And this we use to treat either moderate to severe endometriosis, because those medicines can actually reduce estrogen levels. And remember, we said that endometriosis is estrogen-dependent condition. So endometriosis cannot grow without estrogen. So by taking medications that will actually cut down estrogen production from the ovaries can help reduce that disease. And we typically have patients on these medications for 3 to 6 months, again, depending on their situation, sometimes maybe even longer. These medicines can cause bone loss. So some of these, Myfembree, for example, already has a birth control pill or hormone replacement inside the pill. So there's a lower incidence of bone loss. If we're putting a patient on something like Orilissa, which is just an anti-hormone medication, we may add a hormone with it to counteract some of the symptoms and the bone loss. And again, we're key with really any endometriosis management is continued follow-up. It's not a one-off. It's not that, patient comes to you, I do the surgery, and then I say goodbye. No, the patient continues to follow up, typically every 3 to 6 months, especially in the beginning after the surgery, to really figure out how well their symptoms are controlled, and if what we're doing is the right thing.
Dr. Danilyan,
Yeah.
question here. Why is symptom management, number one, is endometriosis curable? And then number two, why is symptom management important?
Yeah, so endometriosis can be curable. So again, it's estrogen dependent disease. So unfortunately, in order to cure it, we have to eliminate the number one producer of estrogen, which is the ovaries. So, and a patient who is young, who wants fertility, for the time being, it would not be curable for them because we're keeping the ovaries, right? And the ovaries are continuing to produce hormones. So we may temporarily kind of put the patient in remission by putting them on one of these anti-estrogen medications, but they wouldn't be considered cured. Once the medications are discontinued, the disease can recur. Sometimes pregnancy actually puts patients in remission because the estrogen levels, again, are low during pregnancy, and that really helps patients sort of, the endometriosis goes away while they're pregnant and maybe for a short period after, and then it can come back. In an older patient who's done with fertility, the patient who's maybe had multiple endometriosis surgeries, or maybe it's a younger patient who does not want fertility, whose only goal is to end their endometriosis journey, may choose to have their everything removed, including uterus, tubes, and ovaries, and that really decreases their chance of endometriosis ever coming back. Sometimes, depending on the severity of endometriosis, it can come back even without ovaries. Sometimes, so we know that endometriosis is produced by ovaries, but it's also produced from fat cells. That's why heavier women are at higher risk also for breast cancer because of estrogen production. So even if I have someone who's postmenopausal, so their ovaries are not working, or let's say we took the ovaries out, but if it's an overweight patient, we have to counsel them on weight loss because their fat cells are still producing estrogen. And sometimes we actually have to put them on medication that targets that estrogen. It's the same medicine that sometimes breast cancer patients have to go on, right? So it's the medicine that's not targeting the ovaries, it's just targeting this estrogen that's made by fat cells. So it's it's a very complex condition, I would say. So it's not always curable, but a lot of times it can be. And now I forgot the second question. Oh, the symptom management. Yes. Why is it important? I mean, my God, it's all about quality of life, right? Because if our life is miserable, then we can't be happy. We can't live it. We don't know how long our life will be, right? It could be very short or it could be very long, but we want it to be happy as much as possible. There are external factors that we can't control, but I think we should be able to control at least our physical condition and our symptoms of endometriosis. So yes, it's extremely important. And that's why, again, the correct diagnosis is so important because it will help manage those symptoms better. All right, so what do we do different? So CIGC, CIGC, that's a misspelling. So that's our practice, right? Center for Innovative GYN Care. And what is our approach to treatment? We definitely do endometriosis excision, not ablation. We use this dual port method procedure, and this is just a picture of an actual patient. So 2 incisions. You have 1 incision at the belly button, and then a second incision in the bikini line. So how is it different from the standard approach? Especially nowadays, most endometriosis surgeons are using the robot. So with the robot, there are more incisions. They're also located more in the middle of the abdomen, kind of in this arc. I don't know. Can you see my mouse when I'm moving around? Yeah, you can. Okay. So there's incisions kind of in the middle of the abdomen like this, which is not as cosmetically sort of pleasing. We put these incisions for 2 reasons. 1, cosmesis. Second, there's actually less pain than when you have incisions placed laterally or on the side of the abdomen. And there's less chance of bleeding underneath the skin, or called hematomas, which also contribute to pain. So with these 2 incisions, there's faster recovery, again, fewer incisions. There's no hospital stay, so it's outpatient. Whether we're just excising endometriosis lesions or we're doing, extensive surgery for stage 4 endometriosis, all the patients are going home the same day. And they're recovering really at the comfort of their own home. These are done in an outpatient facility with much more personalized care that you would get in a hospital. With hospitals, they're very busy. There could be 100 surgeries going on that day. There's not going to be 100 nurses in the PACU area. In an outpatient surgical facility, there's a 1-to-1 nurse to patient ratio, and it's a much more individualized care. We continue our follow-up after surgery, again, every 3 to 6 months office visits, or more frequently if needed, because we understand that endometriosis is a chronic condition. Endometriosis can come back, and it does come back, and it really requires continued follow-up, because patients, they want to feel that, you care about them. They don't want to feel that they're just, there for surgery and then we ship you off somewhere else. Fertility assessment and counseling, that's very important for patients who want fertility. Endometriosis can absolutely 100% affect fertility, even in mild cases. Even if, in patients who have to do IVF, let's say in vitro fertilization, which is fertility treatment, it could be for other reasons. Maybe it's age related. Maybe it's because of low sperm count. It is still important to remove endometriosis if it's there, to improve the chances of successful IVF. And then dietary changes, with weight loss, and really reducing, again, estrogen production outside of the ovaries. Also making sure that we're decreasing inflammation, because endometriosis can cause a lot of inflammation, which is what causes the pain. And we want to make sure that we're sort of creating a low inflammatory environment, also diagnosing other conditions, whether it's IBS, and we send them patients to GI evaluation, or another common condition, which I didn't mention, is interstitial cystitis, which is IC. And a lot of times it's present in endometriosis patients. During the surgery, we actually do evaluate the bladder. We actually put a camera inside the bladder and look and make sure that that patient does not have findings suspicious for interstitial cystitis, which is chronic bladder inflammation. And that's a common cause of pelvic pain, and again, commonly present in endometriosis patients. So again, treating patient as a whole patient, right? Not just the condition, and really understanding condition and individualizing treatment based on the patient's desires, what their situation is. I've had patients come to me saying, I don't want fertility. I have adenomyosis, which is endometriosis growing in the wall of the uterus. I have horrible pain. I have horrible bleeding. I want a hysterectomy. I want my uterus removed. But other doctors told me I was too young. There is no age. This is not a drinking situation. It's, a medical condition that can affect younger women, and it can affect older women. And again, if that patient understands that they do not want to carry a pregnancy, and they have this very severe debilitating condition that will only progress, so the symptoms will usually get worse over time, and it's very difficult to control those symptoms with medications. And if the patient desires hysterectomy, then that's what we do. Again, you cannot look at it. It's not just a number, or we can't follow a specific protocol. It's really depends on what that patient has, and what's best for them. So in closing, very common condition. So we think it's 1 in 9. That's what statistics tell us, but I think it's much, much more common. So really, any patient that has pain, whether it's during the period or most of the month, if it's a younger patient, or if the pain has been present since teens. For example, if I see someone who's 40 years old and she tells me, I've always had really painful periods since I was a teenager. I was put on birth control pills, and it's just gotten progressively worse. I'm thinking endometriosis as the number one cause. Affects millions of women worldwide. Early diagnosis is crucial, right? For better outcome, for psychological health, and the earlier you diagnose, the more treatable the condition becomes. So we really don't want to delay care so much to where we end up saying, the only option would be to remove everything because there's just so much disease. Another thing is endometriosis can affect structures outside of just reproductive structures, right? We said it can grow in bowel, it can grow in bladder, it can grow in ureters. I had a patient who actually lost one of her kidney functions because the endometriosis grew into the ureter, which is a tube that communicates between kidney and bladder, and completely blocked it. I had a patient that needed complete resection of her colon because of endometriosis. And this is not something that happened overnight. This is years and years and years, long-standing delay in care, or misdiagnosis that led to this. Endometriosis symptoms can vary, right? Pelvic pain, heavy menstrual bleeding, fatigue. So anytime, it's very simple to do laparoscopy. It is a critical step in the correct diagnosis and treatment, and I think it can change a patient's life. Yeah.
Oh, yeah. Thank you so much. I think we have several questions in the chat box, so maybe we can dive into those. Excuse me, the lights just went off in my office.
Okay. Okay,
let's go ahead and dive into the questions, Dr. Danilyan. Those questions are, we have a question from Chelsea. Do you see the comment in there? It's, if you have a moment, she's asking if, can you discuss diet and lifestyle implications in place of pharmaceutical interventions? Have you seen excuse me, have you seen cases where lifestyle changes significantly impact the disease progression and or symptom management?
I think it can definitely have a role in symptom management, for sure. I think in mild endometriosis, there's definitely, it's appropriate to, if the patient, for example, prefers to not do any birth control pills or any hormonal management. And of course, with mild endometriosis, typically we don't treat it with the anti-hormones with kind of more strong medications. So I think if the diagnosis has been made, because remember, if we haven't done laparoscopy, we don't know how severe this endometriosis is, or if it's even endometriosis. So if we're suggesting dietary treatment, we don't know what is treating. So if you want to do dietary management from the start, you're really just managing your symptoms. But if those if those dietary changes are ineffective, then the next step would be laparoscopy. But really, you prefer to do laparoscopy first to diagnose the disease, excise it, and then if it's mild, sure, I think that it's appropriate. Diet, again, so a lot of patients do Mediterranean diet or anti-inflammatory diet, so diet that reduces your weight if it's someone who is overweight, and decreases inflammation. But again, it's very important to know what stage and what is it that we're treating with diet.
Great.
All right. And Lydia,
So
you want me to just go to the next one?
yes.
Somehow it jumped
Mary
up.
Lynn has several questions.
Yeah, Mary Lynn. So related to confirmed diagnosis in a teenager, is a generally recommended practice to attempt to stop periods after excision surgery in order to preserve fertility. I mean, if you stop periods, it's not that you would be preserving fertility. The stopping of the periods a lot of times helps with endometriosis symptoms. So if the patients mostly had pain during their periods, and even after surgery, kind of majority of the pain is happening during the menstrual flow, then it would help to be on medication that would stop periods. And it doesn't have to be any type of strong medication. It's just a birth control pill that's taken continuously. So instead of stopping the pill and having a period, you just take the pill, start one pack and then go to the next pack without the placebo. So again, this is not so much to preserve fertility, but help with symptoms. If we're talking about medications that actually put you into temporary menopause, those anti-hormone medications that I was talking about, those can be helpful in moderate to severe endometriosis to A, control the symptoms, and B, to treat the disease so that could potentially affect fertility. So indirectly, I guess we're helping with fertility by putting a patient on those anti-hormone medications. So would you ever recommend, or at what point would you recommend a teenager seeing a fertility doctor in order to assist in preserving fertility in the future? Yes, I mean, you can, depending again on the stage of endometriosis. So I'm assuming this is already diagnosed, right? We've done laparoscopy, we've diagnosed endometriosis, and let's say we found severe endometriosis, or maybe there was endometriosis cysts on the ovaries, in which situation we're always concerned about healthy ovaries remaining and eggs remaining. And in that instance, definitely a fertility, not so much evaluation, but preservation with egg freezing, right? So let's say if it's someone who's 17 or 18 years old with endometriosis on the ovaries, absolutely, we want to send them to a fertility doctor to get egg retrieval, which is when they take out eggs and freeze them to preserve their ability to have children in the future when they're ready. So that's extremely important because these endometriosis cysts typically do come back. That there's a higher risk of recurrence the younger the patient is. So we don't want to keep doing surgery on the ovaries, not having saved those eggs, frozen those eggs. And are you aware of any support resource groups specifically for teens dealing with endometriosis? They have been difficult to find. That's a great question. I don't think anyone has ever asked me that. I don't know of any teen specific groups. I know of course, there are many endometriosis groups, but I don't know of any that are specific for teens, but it's something definitely we could look into and do some online search for sure. Yeah.
Yeah, we can look into some support groups and provide that resources
Yeah.
via email. We have one more question from Lydia. Can you see it?
Yep, I see it. I have had several laparoscopic myomectomies, but my fibroids grew back. I also have endometriosis and adenomyosis. It was recommended I consider having a hysterectomy, but there are other options I'm considering, such as IUD and UFE. Do you recommend either to help my condition? UFE seemed like a favorable option since it's non-invasive outpatient procedure. Yeah, this is a great question, actually, because it has a lot of coexisting conditions, which are very common. Again, fibroids, right? So myomectomy is a procedure of fibroid removal. And fibroids are estrogen dependent tumors, just like endometriosis, and they do tend to come back, especially in younger patients. So one big question is, do you want to preserve fertility, right? Because the uterus is there to carry a pregnancy. It's a muscle, looks like an avocado with a pit removed. That's all it is. The uterus does not produce hormones, it doesn't do anything else. So the question is, do we need to preserve the uterus for fertility? If the answer is no, so it's kind of like an algorithm, fertility, no, then we're looking at choosing what's the best treatment that's going to address all of these different conditions. So you have fibroids that have come back. You have adenomyosis, that's also an issue of the uterus itself. So you have these two conditions going on in the uterus, and the best way to treat both of them at the same time would be to remove the uterus. Let's look at other options. So we don't want to remove the uterus, look at other options. So IUD, what does the IUD do? So IUD doesn't treat adenomyosis and it doesn't treat fibroids, it treats the symptoms. So IUD a lot of times helps with heavy bleeding. But for adenomyosis, it's not very effective. It's much more effective just for women that tend to have heavier periods, or maybe for women who have endometriosis and tend to have more pain. But for heavy bleeding due to adenomyosis, IUD is a lot of times ineffective. For fibroids, it depends on where they're located and how big they are. IUD, again, a lot of times will not be effective for fibroids. Just like a birth control pill, or a shot, Depo-Provera shot, or a patch, or a implant. So these are all just hormonal contraceptives that can happen to have sometimes with pain, help with pain or bleeding. But again, with large fibroids, multiple fibroids, or adenomyosis, they're much less effective. UFE only addresses fibroids. Although I have seen many patients get uterine fibroid embolization for adenomyosis, but physiologically, that really does not make sense. So uterine fibroid embolization is done by interventional radiologists. It's a minimally invasive procedure. They go in through a vessel in the groin. And what they do is they target blood supply to fibroids. And by blocking that blood supply with little tiny particles, because you're cutting off the blood flow to the fibroid stops growing, and it can also actually shrink, reduce in size. It doesn't help with adenomyosis. It really doesn't, because unless you're able to embolize the entire uterus, the adenomyosis is still there. It has much different sort of causation and growth than fibroids. So just cutting off blood flow to the entire uterine muscle is not going to necessarily make adenomyosis condition less painful. If anything, it can produce more pain. So if this is sort of a very long-winded answer to your question, it's really, what do you want to do? If you want to address both conditions, adenomyosis and fibroids, definitively, meaning that you do one thing and it will 100% absolutely work. Then you do remove the uterus, which can be done laparoscopically, 2 tiny incisions. So really it's very minimally invasive. And then you're done. Fibroids never come back. Adenomyosis never comes back. If you want to do this, try this and try that, then you go, again, conservative routes of IUD, UFE, all these different things that will not be effective against both conditions at the same time. And these conditions can resurface again. So maybe these things help temporarily and then they don't help anymore. So that's, it's removing the uterus, of course, is a personal choice, but it's number one is fertility. Also, if you desire fertility, you don't do UFE because uterine fibroid embolization, although there are reported pregnancies after that procedure, it does greatly reduce your ability to conceive. There's no question about that. There are multiple studies showing even reduction in ovarian hormones because some of the blood flow is affected to the ovaries. And so you absolutely, if fertility is your number one goal, you do not do UFE. Then you have to do IUD or some type of hormonal method to just try to manage symptoms and, hold out as long as possible. But again, if you're not trying to preserve the uterus, there's really going to be one treatment option that's going to be the most effective. So rather than going through all these different things, and you've already had several myomectomies, and it's, it's difficult to go through years and years of treatment and surgeries, and it's just like never ending. And everybody has a different journey, of course, and it's hard to really judge somebody and say, well, why didn't you do this sooner? But eventually with adenomyosis, especially, a lot of patients choose to take out the uterus because they find that treatment most effective, and they're always very happy, but you have to, of course, be emotionally okay with that decision, and that's very important.
Definitely a tough decision to make. Excellent, Lydia. I hope that answers your question. We do have a few minutes. If you have any lingering questions that you want to ask Dr. Danilyan, we're here. I'll give you a few minutes. If not, we can go ahead and wrap this up. I want to thank you all for joining us. This is, as I've mentioned, as part of our Ask the Experts series. Just to wrap things up, I think this, just to summarize it, I think Dr. Danilyan emphasized the importance of diagnosis, seeking out treatment. So if you have any questions or need further consultation, we are here. We are a resource. So I know someone asked where we were based in terms of our practice. Dr. Danilyan, she's in Rockville, but we do have locations in New Jersey as well as New York, and one in Virginia. Am I correct, Dr. Danilyan?
Yes. And also, I want to say, we see patients from all over the country, and sometimes even outside. So we do have patients who travel directly to our center for treatment. That's extremely common. And typically we do consultation by phone or by, video, and patients will just send their, records. So really in-person consultation is not necessary, because remember, with endometriosis, everything can be completely normal. Pelvic exams a lot of times are very limited, and even ultrasounds are normal. So it's really discussing the symptoms and, making that decision to proceed with laparoscopy. That's, and so all of that can be done sort of virtually. And then the patient would come for the surgery. So they come the day before, they do the surgery, and then day after we see them in the office, and then they can go back to their home, typically 2 to 3 days after the surgery. So it's a pretty quick process. We also schedule very quickly. We don't have, 6 or 9 months or whatever year wait. A lot of times if it's urgent, I will get the patient in for surgery within even a week. So again, everybody's situation is different, but we're here to help. And we have all of our surgeons are experts in endometriosis. So regardless of whether you come to Rockville Center or the New York, New Jersey Center, you will get the same excellent treatment. I think I see Chelsea with her hand raised, but I'm not sure if that's.
I think Chelsea is just waving by.
Oh, okay.
Thank you, Dr. Chelsea.
No, I'm sorry.
I'm sorry.
Can you hear me? I actually did have a question.
Okay.
I'm sorry. Yeah, let me lower my hand. First, thank you for answering my question. I so appreciate that. And actually, Dr. Paul, is it McCole?
Yeah.
I feel like I butcher his name every time. I'm sorry. He did my excision surgery in 2021, and he found that I had stage 4.
Oh.
So I guess that was kind of in relation to my question about lifestyle and diet. So just knowing that the stage 4, I mean, does that change anything? Maybe would you suggest that no, it's probably more aggressive and
stage 4. Yeah, stage 4 is really difficult. It's really difficult to treat. Sometimes a lot of times compare it to like cancer, right? Because although it's not something that you can die from, but it's so aggressive, it just spreads to all the structures. So I mean, it's not wrong to do diet changes. Absolutely. It's not going to hurt, but you definitely have to do pharmaceutical intervention at the same time. You have to target, that estrogen, because, your ovaries are producing estrogen. I mean, you could be 100 pounds with, not an ounce of fat, but your ovaries are there and they're functioning because they're doing what they're meant to be doing. So you have to target that estrogen production, if not surgically, then pharmaceutically.
Absolutely. Okay, and I had one more quick question, if you don't mind. What determines, any subsequent procedures, like any surgeries? I'm guessing I might need another one because my symptoms haven't improved too much, and I'm kind of guessing, like, how do you guys gauge that when we need another surgery?
Yeah. If all the imaging is clear, so let's say there's no cysts on the ovaries, then yes, it's symptom related. Also related to what is your desire for fertility, right? Because also it's not only do you need another surgery, what type of surgery do you need? If it's stage 4 endometriosis, are we just going back in and kind of cleaning things up, but leaving, the ovaries, the uterus, everything in place? Or are we going in for, the very last time to clean everything out? So, it's going to depend on how severe disease is and really what your symptoms are too. Yeah.
Right. Okay. Thank you so much.
Sure, of course. I think there's one more question from Susan.
I think she's making a comment.
Okay. Okay. That's good.
Yes. So yeah, we have 2 minutes. If we have any questions, we are here. Otherwise, I will also be emailing you a lot. I know some of you have asked whether or not this recording would be available. I would email it to you immediately. And if you have any questions that you forgot to ask during this webinar, you could reply to that email and I'll get it to Dr. Danilyan and get you a response. And if you need to schedule a consultation, you reach out to us. I thank you all for joining us for this webinar. And we hope to see you soon. Enjoy the rest of your evening. We're going to go ahead and log off now. Dr. Danilyan, you can stay on if you like. Let me stop recording.